Welcome to the NP-POW videocast, a space where we will talk to healthcare experts who will share their POWs, or pearls of wisdom, on an array of topics. I am your host, Dr. Julia Rogers, a certified nurse practitioner. And today we are honored to have Dr. Douglas Mazurek with us to discuss differentiating and treating respiratory illnesses during cold season. Thanks for joining us today, Dr. Mazurek. It really is a pleasure to have you on the videocast today.
My pleasure to be here. My honor to be here. Thank you.
First, can you just tell us a little bit about yourself and your background?
So I am a recently retired pulmonary and critical care physician, graduated from Northwestern in 1989, internal medicine residency at Indiana University, and then pulmonary critical care at Loyola University. So board certified in internal medicine, pulmonary medicine, critical care medicine. And I've been in private practice really 1995 to earlier this year.
Lots of experience.
And some other things as well, other things that have been a little bit more focused toward inpatient and ventilator care.
Wonderful. It seems like you're the expert to give us all this information today. So again, thank you for coming. As we enter the fall and winter months, what kind of distinctive patterns do you observe in pulmonary illnesses of patients that are presenting to your office?
So, I like to think of it as moving away from a season of airway inflammation, poor air quality, smoke, allergies, pollutants outside. We're inhaling what we're working around outside, and we now shift really to more of a season of infectious illness, and that is entirely, almost mostly, viral illness. So while you can have, we all are familiar with common summer colds, that sort of thing. In general, common cold becomes a really important reason for patients to show up in an emergency room or in a clinic. So, I think we must then also need to focus on some epidemic, quote unquote, yearly epidemic influenza type infections. So it really is a mindset away from the routine pulmonary medicine stuff, more toward exacerbations of chronic disease or infections with other things.
Do you think fall, winter, or spring, do you think that there's a particular season that is more challenging? And do you think it is because of just air quality and places that are colder or warmer that could trigger someone's, symptoms?
Well, I think winter, late fall, winter, and spring are challenging months because of infection. So, since that's the category of disease we can really medically do, and speak out of both sides of my mouth here, at the same time do the most about if it's a bacterial infection, but at the same time, if it's a viral infection, it's going to just be support. So I think that those are really the challenging months for us, because then we also have volume to deal with because people are there. That said, I just think there's much more awareness about air quality and, thinking about, living here in the Midwest where we have, now constant reminders of wildfires in Canada, and every day the sky is blue, but it's not really blue, and, the same way it used to be. So, I think the issues are there in better months, warmer months, but they're a lot more focused on those people who, you've been seeing for years, who have recurrent problems. Whereas I start in the fall and then the winter and spring, really seeing people who maybe have been doing fine for a while, or you haven't seen ever before, but show up now with a new respiratory complaint.
Speaking of different types, walk us through the most frequent respiratory complaints that you see during these colder months.
So, the classic pulmonary disease symptoms are cough, shortness of breath, and chest pain. So, in general, really mostly cough and shortness of breath. I think we end up with chest pain going more toward cardiology. Other things, of course, then aren't respiratory complaints at all. They're fever, chills, sore throat. And there's kind of those in-between things that are runny nose, again, scratchy throat. And then there are just constitutional complaints, myalgia, anorexia, weakness, and just generalized dizziness, those things that really frustrate us because patients will find them to be very significant, and practitioners just kind of roll their eyes and I didn't get good sleep last night. I didn't feel great today, but they're really prominent, especially for elderly patients. The other thing, of course, is clearness, clear thought. For a lot of elderly patients, they might not be at their regular day. It might be a family member that brings them to the office who says, hey, mom isn't sane. And that's always, possible link to something else.
Well, a lot of these symptoms that you described are common with a lot of different diseases: cold, influenza, RSV, pneumonia. So it can be really challenging. Are there some pearls of wisdom or hallmark clinical features for each of these conditions? For example, do you have or see specific patterns? Do you look for specific symptoms for each disease process or different quality of symptoms? What really makes you distinguish what disease process it is, whether you're at the office or at the bedside?
So, I think there's two different big categories there that you bring up. One is, kind of how do we look at the patient, so that I'm thinking what's going on, how assessing the patient and having a format in the back of my mind to think about that. And then, of course, the other one is what are the patterns of illness for these things? And is there any way to suggest or hedge a bet or think, hey, I've got this more likely than I have influenza, more likely than I have RSV, more likely than I have common cold. So an assessment, I think that the biggest things are the basics again. You really want to talk to the patient. You really want to get a good history. Of course, we are dragged away from that. I still think that's important. Do that, then you look at the patient, again, an overall picture of the patient. Really, these are fairly brief exams. You're going to look in the patient's upper airway. You're going to feel for lymphadenopathy in their neck. You're going to take a listen to their lungs. I mean, generally, viral illnesses don't often have signs of consolidation, or maybe even crackles for that matter. So you kind of think of it as respiratory complaints with a clear exam when you listen to patients' lungs. Of course, you want to listen to their heart, I think, as well. And then you want to look at vitals. Does the patient have a fever? What are the blood pressure like? And, that big picture, is this patient diaphoretic? Is this patient looking stressed even though they're telling you, I don't feel that bad? And then, of course, and this is always difficult and unique to each of us in our practice settings. So you want to go back to your context at the time. Am I in a school clinic in August waiting to clear kids for going to school? Am I in a clinic in December where those kids are back from school and sick? Am I in a nursing home? So I think that it's important then to use what all practitioners have and we're in a continuous process of developing this our entire practice career forward. That idea that every patient visit, and I know this is hard because we get into what's the best way to say this, kind of the industrialized idea of taking care of patients, where we're just rolling through one after another. I've got my momentum, I'm charting, I'm doing that. But you've got to also be thinking, this is a routine case of COPD or whatever, but every routine case brings something to your clinical acumen. Every time you see a patient, every time you listen to a patient, and you kind of at the end of, you're summing this up, you may be sitting there with the patient and a family member, and in the back of your mind, you're thinking through, well, I think this is something important. I think this is not a big deal. I think this is here's your refills, that kind of thing. But you're honing that skill so that you get that sense. And this is hard because this is not something that you can look at chapter 5 in Dr. Rogers' book to understand. This is something you're going to develop while you're in the field, while you're working with people. That sense of, hey, this patient, there's something wrong here. This patient's got to go and get something more. So, I mean, I think from an assessment standpoint, don't need a lot of fancy labs. I mean, I think the one thing I didn't add, of course, would be oximeter. I mean, the oximeters are ubiquitous. People have them. Many have them at home after COVID. And so that piece of information, for the vast majority of people, it's not going to be. But, I mean, it's a nice, simple one piece of data that you can use to really separate out somebody who's really sick. If you put a finger on an oximeter and their sats are 87, well, they're probably not going home with a script. They're not it. They're probably doing something else. So it's useful, but that's going to really be the exception and not the rule. So we've assessed or thought about our patient, and then we're going to put that in the context of, well, what are the big things I'm looking for to fall, and I've got to worry. I've got mom and the kid, or I've got whoever saying, hey, I got to go to work tomorrow. Should I do that? So I'm thinking in the back of my mind, what is the diagnosis? And frankly, this is again, imprecise kind of clinical medicine care. Does making a diagnosis here make a huge difference to anybody? It's going to change what I do if I have a common cold versus influenza versus RSV. And a lot of the time, the answer is no, right? So it's important to patients. It's important to ICD-10 codes so that you can send them a bill. So if you can come up with something that sounds better, everybody feels comfortable with it. And that's where I think you try to get to the idea in the back of my mind. I think a common cold, I'm thinking these are people who show up, got a lot of nasal symptoms, a lot of rhinitis, secretions. Now, the big thing about secretions always is color. Right? We think, boy, if I got green secretions or I got really thick yellow secretions, that's, every family member pretty much comes and wants an antibiotic, right? Colored secretions. Right. That's a tough one in the office to say no to. But, generally, is that very useful? Not really. That's, I personally had a sinus thing, and I'd seen my ENT. This was recently. Secretions look, I thought myself, I'm like, boy, these look terrible. They're really purulent. They're awful. This is in July. So you're thinking, what the heck's going on? And, I was skeptical. I went to them and they said, oh, you know what? Let's give you a script for Flonase. And, I was impressed that was spot on. And that was, they did just a exam. They didn't, it's a fellow. It wasn't like it was a deal. So, secretions are something we focus on, but not sure how much they mean. Look in the patient's throat. They will have, in addition to common cold, in addition to sinuses, you're thinking about mouth, right? So you got sore throat, the scratchy throat. And then you get a little bit of the stuff that is more constitutional. Headache, the classic quote unquote, the flu, which a lot of people, make synonymous with, I have diarrhea or I have some nausea, but that's really not all that common when you're thinking about things. Common colds also can have low-grade fevers, conjunctivitis, tend to be illnesses of short, time of incubation, short time. Since I was at the party the other night, now I'm feeling sick as a day or 2 days later. Good news, of course, for the common cold is, 7 days, whether I do something or not, you're going to be better. So that one's pretty, I think, solid. I think we'll come to it a little bit later when talking about things. What are you going to do for that patient? Save that. Let's get to common symptoms for influenza. So influenza, again, really kind of fever, a little bit on the low grade. This is not the 99.8 typically. Usually it's someone 100 to 100 on that, so maybe even a little higher, or prominent to it. And this is usually a dry cough. It can be moist, but in general, we think unproductive. Lots of constitutional symptoms. These are the patients who are really achy. These are the patients who feel really poor, have no energy many times. They still have complaints of nasal congestion. They can still have about 20% of the time the GI complaints, but they're not, again, all that. The hard part for here, and this is, again, people I work with, is elderly. A lot of elderly people will show up, and their main findings will be non-classic findings. I just feel bad, doc. I felt better 3 days ago. I get up and everything hurts, and I don't feel like doing anything. Again, a incubation time, 1 to 4 days. Sometimes people will have pinpoint accuracy and say, on August 10th at 4 p.m., I noticed my first cough. But that's, not the rule. It's more. These patients, again, you're also thinking, epidemic classic time. So I got to be thinking about somebody who is, sick in November or December, is fitting this as opposed to someone who's in my office saying, oh, they could still have influenza. So, RSV, again, a lot of non-specific stuff, a lot of upper airway stuff, sore throat, nasal congestion, rhinitis, malaise, and cough. Now, the thing I guess that I think about what RSV, that gets me thinking that that's more of an issue is it really ties to the thought in pediatrics, diagnosis of bronchiolitis a lot of times is linked to RSV. So bronchiolitis, I think you're thinking more, and I think this is true also for adults. I think that you're thinking more of this is not just, shall we say, an entryway to your airways. It's not just oropharynx, nasopharynx. It's more in the airways, right? So small airways. Now we're talking about inflammation. We're talking about wheezing. So I think that's the shift that ups the ante in RSV versus the other illnesses is really talking more about stuff that the clinician's going to get, right, pay more attention to something when you see somebody than somebody who you hear a clear exam. And I think that might turn me a little bit more toward RSV. These patients, again, non-productive coughs are shortness of breath. And these tend to be sicker patients. So there have been, studies that look at cardiac admissions in elderly people being more linked to RSV. RSV being common in hospitalized patients. So thinking of bringing them in, and as you're bringing them in, do you do a test looking, again, incubation day right in that area of a few days. Could be a couple days, could be 5 days. Again, how long does this last? Maybe a couple weeks. And this is something that can strike all ages. I think the thing that you don't want to miss then is really kind of the peak of this. Where are we going with all these diagnoses? What do I need to really know about? And that would be pneumonia. Talking here about community-acquired pneumonia. What are the big things here? Well, this is really usually, the bona fide fever, but the fevers here going to roll over the map because I know we can all point to cases, usually older folks, who have no fever or have a 99 fever. The next day they're a 101. So it's still, again, if you see somebody with 102 temp, that should, get your attention, and I think it should make you think long and hard about that full pulmonary exam. Am I going to cuss them out? Yeah, probably. I want to hear for dullness. Am I going to palpate them and look for phenolus? Am I going to listen for signs of consolidation like signs? Cough here, very prominent, but this is not the non-productive cough. This is the purulent cough. And again, this is not nasal secretions that look green, yellow. This is something that you're sitting there and the patient can't indulge and cough something up. So again, a little bit more prominent. Also, shortness of breath and constitutional symptoms are here as well. Most of these patients, they're not going to feel good either. They're going to have aches. So this is really where I think, if you're really thinking pneumonia could be a player, you're going to end up having no choice but to probably the chest x-ray. That thought or not. Now, of course, you're skilled enough and lucky enough, and you have an ultrasound unit in your practice site. I mean, that you can look for signs of consolidation. You can theoretically, it's just become another point of, I think to weigh what you're thinking about. I still think you end up with a chest x-ray, but you do have other bedside imaging modalities. Again, the thing you don't want to miss is pneumonia. Pneumonia is going to usually have that abnormal exam that, usually the respiratory viral illnesses.
Influenza, I'll kind of piece each of these out. Influenza still is a significant concern each winter season. And I know people think, oh, you just have the flu. It's really not that big of a deal. But sometimes even influenza could turn into a pneumonia. So when do you recommend even antiviral therapy for influenza or just supportive care? Do you have any really treatment protocols for influenza itself?
So, I think influenza I agree with you. It's tough, and especially in the era of COVID. Now the stakes in this game are very high. Elderly patient with influenza, maybe some additional comorbidities. So the table is really set to develop pneumonia. The table is really set to have a severe respiratory infection. And this is something you don't want to miss. The same again with COVID. You don't want to send this person home if that's not the right place for them. So, this is also a toughie from the standpoint of the clinician as someone providing a service to a customer. So, people know oseltamivir, Tamiflu. People know about its existence. I think there's, in the popular mind, the Americans love taking pills, love taking those things. Even if we don't need them, we'll take vitamins or whatever. So, they know there's a flu pill there. They're going to be interested in getting it. If I get half a day off of work, I came to the office, I'm only 45, I feel kind of lousy. And you see me and you say, hey, Doug, I know you feel lousy, but all you really need to do is go home and have a cup of tea and take a nap. And I'm not feeling too good about that when I see my copay. So what I end up thinking is, I know this pill exists. Are you going to give me it? And, the idea that, it's not a cure. It's going to lessen your symptoms. So you're going to feel better, right? So isn't that what medicine's for? Better. So I think this is a toughie because, frankly, I agree with you. If you've got the 80-year-old diabetic, lung disease, heart disease patient with influenza who shows up, this is probably somebody, provided the kidney function allows it, this is probably somebody who should get some oseltamivir. But I think you're going to find a lot of times where ambulatory patients are going to. Remember, Tamiflu is only really basically an oral agent. So, this is not an issue for outpatient practice. I have had times where I've had people on a ventilator and thought they had severe influenza, and we Tamiflu pills. I guess we dissolved them, put them into a feeding because still IV formulation of it. But unless there's a run on Tamiflu, remember 2009, H1N1, a bit of a run, and people had Tamiflu in their house and had it around because they didn't want to be behind the cough if they got sick. So if that doesn't exist, Tamiflu is pretty easy to get. I don't think it's that particularly expensive. And I would tend to really gravitate toward treating older, sicker people. I don't think I want to treat kids with this at all. the young worker, not unless they were really upset in front of me. Is it important to know for sure if these people have it? I think, again, you're reassured, and these are non-invasive tests, just a swab. So they don't involve getting stuck. Don't know the cost off the top of my head. And availability is an issue, as we saw with COVID, with this type of test where they're trying to figure out the COVID differences, so we're doing them all. But if it's available and it's in the back of your mind, and certainly if it's going to make you make a decision about treatment, then I think you're going to go ahead and do one of these, nasal swab. That's generally the PCR type tests. It can also be antigen type tests, depending upon what you have in your practice or what you have in your hospital. To get them. Again, the thing to talk about influenza is at least there's a treatment. RSV would be a good contrast to it, because in RSV, you also have a detection test that's non-invasive. But at the end of the day, does it make a difference to know that? Because there's not a specific therapy. And there's ribavirin, which we've thrown into cases in ICU past where added because their patient turned out RSV positive on a ventilator. Did that ever help them? I don't know. Did it help me more? Probably. I felt better about it. I was doing something. That, of course, not good. So you're not going to go out and tell somebody, boy, I need to really know about RSV because that's going to change a lot of what I do. It might make me think about an inhaler. But again, it's going to be hard to do a bronchodilator unless you're wheezing, in which case you can't hide that. The patient, you're going to find that out, just listen to them. So, therapy, it's really Tamiflu, not a lot. These antiviral things can be.
Well, and the other issue with antivirals is that sometimes by the time a patient presents, especially to an outpatient clinic, the time frame has passed of when you should be starting the Tamiflu. And so they don't understand that either. So sometimes just waiting it out is the same amount of time as they would have with the flu as if you gave them the Tamiflu.
Yeah, I think that's a really good point to bring in that I didn't mention, and that is, Tamiflu is only a player early. If you don't get Tamiflu, within 5 days, it's not even worth doing it. So if they show up, day 6 or day 7, and they're still feeling bad, there's no point to even doing it. And really, it's best if they show up on day 2. But, again, a lot of people who show up on day 2, really, supportive care is still going to be the number one. I think the nice thing about them, it's not a nice thing about them coming late, but the thing from a practitioner standpoint about a patient coming is it really leaves you an easy out. Because they say, hey, I've been sick since, in this case, the last Monday, and I'm here and I've got these respiratory symptoms. And gee, I know about Tamiflu, you're going to give it to me. And then you can say, hey, it doesn't work. After 5 days. And I think usually people will accept that much more than they would accept that. Don't worry.
I agree.
So I think that's kind of, for me, a good out in a practice situation is that unless it's in that 0 to 5 day category, then you got different situations because then you're probably going to end up giving. If you come late, you can pretty much say, and just really this is a hand-holding thing. Say, hey, tomorrow the sun's going to rise. It's going to be better in the next few hours or days, and you'll be back on your feet. Now, of course, if it's not better, then it's probably not influenza that you're dealing with. You're dealing with something else. It's important to keep that in mind.
You brought up RSV a little bit. I don't remember treating a lot of adults with RSV when I first started in practice. So I'm curious, have you seen a huge shift with RSV in adult patients? And do you feel like there is any treatment for them versus what you would do for a child? Because most of the time, children are admitted to the hospital with RSV, but adults, you do it a little bit differently.
I think this is a really good point, because I agree with you. You know, I'm practicing for years and years and years. RSV was always something that I remembered from my 6-week pediatric clinical rotation in medical school. I don't hear anybody talk about it. American Thoracic Society, or any of these big meetings until the last, I don't know, 5, 6, 7 years. Not been that many years. So where has it been? I think it's important to realize that just, you know, our knowledge continues all for this. And I think, and I would be pointing at myself in this, because a lot of times I tend to be kind of a lumper and splitter. You know, what difference does it make if it's RSV? It does make a difference, which, you know, I think we'll get to as we continue to talk, because really the difference is prevention. But I think probably from the standpoint of research and thinking things through, I think there just was kind of a bit of laziness. Maybe that's not fair to the researchers about, you know, it's just not a viral illness. But what is that going to do? And in the case of RSV, many times it's not a primary illness for the adult patient. For the child, it's the first time they're getting RSV. So they're the ones who are going to show up with a lot of airway inflammation, colitis. For the adult, well, I had RSV 30 years ago. So I got a few lymphocytes in my system somewhere who remember that, and they're ready to roll. You know, they're ready to rock it, knock it out when it comes. So for them, they just look like any other viral illness. I think with more rigor and more attention being paid to causation and, importantly, prevention, that's where the idea of is it important to know if RSV is there. So that primary RSV infection, again, in children, we're thinking about, you know, the 2-year-old who's wheezing, who has asthma, who's got the bronchitis situation. And so for them, you're right, that patient's getting admitted. That patient looks pretty sick. That patient has parents who are afraid to take it home. You don't have any experience with an inhaler, and, you know, kids, not always the easiest thing to do to get inhaled meds. But if I can keep them in the hospital, as a nebulizer, for example, you know, a day or two, and then they'll be up and ready to go. The hard patient population for the adults, in my mind, are the comorbidity patients. And really, a lot of the COP, and this seemed to be pretty common in my COP patients the last few years, thinking about, well, heck, they don't did my influenza swab, they have influenza, chest x-ray is clear, but they're, you know, they're here with maybe a little bit more severe illness from respiratory infection. So what I haven't been in practice long enough with RSV vaccine being available to really say to you, did that make a difference? Because that's really the test in my mind, would be like, hey, well, you know, I'm going to start telling all these patients, and, you know, patients get really savvy. It's out there in the media, and they come to you and say, do I need RSV vaccine? And, you know, I don't know, 7, 8 years ago, I've been like, what, why, where? And, you know, more recently, I'd be like, yeah, you know, I think we need to get that, and we should go ahead and see what happens. But, you know, I'm retired, so I don't really know. Is that going to change that story for them? Is that going to cut down some of those patients' visits, some of those antibiotics and or treatment, steroids, self-treatment for the exacerbation? I don't know. I do think that it's a player in this arena that we just haven't either been, you know, we've convinced ourselves this is a pediatric illness, and it's an infectious disease. Infectious disease doesn't say I'm only going to have kids, right? So well, why wouldn't we think that? But, you know, we just got trapped into that mindset, and RSV was something we didn't have wherewithal or the thought to look for. I do kind of feel that it is a significant player as a reinfection. And again, the kids are in schools, home for Halloween, Thanksgiving, Christmas breaks, and then they, my grandpa parents get re-exposed to them. So that population where they really wouldn't see RSV with other adults, they have exposure to it.
Sure.
Again, supportive care, unfortunately, real interventions.
Let's think about pneumonia now. We know that that's also challenging because of, in making some diagnostic decisions in respiratory, you have to decide whether it's viral really or bacterial in order to know if you're going to prescribe antibiotics or not. So is there any characteristics, even on x-rays, that you would see that could differentiate a viral from a bacterial pneumonia?
So let's go down the road of thinking we can actually win this fight. So we can actually understand that and solve it and feel confident all the time that I'm in the right lane of bacterial lane or my viral lane. So we begin that way. Again, bacterial, you're really thinking about the presentation of patient who fever, has thick purulent secretions. Do my examination of them, I hear some crackles, bronchial breath sounds, I percuss them, they're dull. They have decreased tremors. I do some labs on them. They tend to be people who have elevated white count with neutrophils, right? They tend to be patients, if I'm lucky, they have a urine antigen positive for strep. They have a Legionella antigen. And I do a chest x-ray and they have classic lobar pneumonia, right middle low, right lower low pneumonia, maybe a pleural effusion. If I go to the viral patient, that viral patient has, I think, a little bit more of the constitutional symptoms. So these are the patients who are a little more weak, algia, headache, maybe GI symptoms. They have the fever, but that fever maybe is 100, 0. I go to the lab, I take them in the lab, and they have elevated white count, but their lymphocytes predominant. They're not necessarily polys. And I look at a chest x-ray, and the chest x-ray doesn't have a lobar pneumonia. That said, these are often the patients you look at end up in the ICU with an almost ARDS-like picture because they have that atypical pattern and easy bilateral infiltrates. That's it. Sometimes you'll have some sort of serology or a nasal swab that will help you make a diagnosis. And then rarely, frankly, basic things like endoscopy, procedures to go and look for answers. We're here, we're idealists, and we think we can actually do this. In reality, it's hard to do that. It's hard to have all those pieces in place at the same time. And of course, patients over time, these illnesses are evolving. So it's difficult to say that, day 1 versus day 4 is the same and it's going to allow me the same diagnostic certainty. So in reality, I think what you end up doing is you end up, if you have information that allows you to make a play, influenza positive, well, that patient's going to, and they're sick, they're going to always have sultamivir, or is going to always have that. Or this patient looks really sick, I think they need some antibiotics. And I got to, cover the possibilities because I don't want to end up behind a patient behind a. So I wish I had the magic bullet for you guys out there on the front lines to say, do this, and it will always be bacterial pneumonia, but I don't. That said, sicker patient, more toxic looking patient, I think about bacterial.
Sometimes there's a lot of people that I precepted that are saying, why don't you do a throat culture and then you'll know if it's bacterial. But I feel like, that takes too long to grow out. So if you don't give an antibiotic and it's somebody that has a lot of comorbidities because you're waiting for it to grow out, you could really cause them to be severely ill, without giving them something. So can you just touch on, throat cultures that you could do in the office? When would you do those? When would you not do them and just give them an antibiotic without waiting for something like that?
I mean, I think, and this is going to, I think I could get some heat for making this statement. A lot of times, if you think that that person has something that might be the strep throat, the biggie here, right? We're going to miss. You don't want to be behind the 8 ball, and you're not going to wait for a culture, or you're going to have a swab or something that's going to come back, and results is its own issue because results. There's always a sheet of paper at the bottom of the stack, right? So there's always a sheet of paper that somebody sees 4 days later, a week later, in which case you've done a test, cost the patient something, and is absolutely worthless to their care, right? And it exposes you to liability because you didn't follow through because you were you're exhausted, you've been charting for 80 hours, whatever. So a lot of those patients, I'd say, if you're really feeling that way, then you're just going to treat it. Now, younger patients who you think are viral, these are patients, provided that as a customer, you can steer them, you can sit down, have the rationale talk about antibiotic resistance, about how it's good for all of us that we use antibiotics, right? But, let's be honest, a lot of times you can do that, and that's your time, and you should do that. I think we need to try to be as reasonable with it and try to educate and share information with our patients as we can. But if I'm going to end up in a scenario giving antibiotics to these people, then these are the guys I'm going to give amoxicillin. These are the guys I'm going to give doxycycline. I'm not going to give them cefixime. I'm not going to give them the newest agent that a drug rep brings by that has ridiculous antibiotic coverage, and it's not really designed for patient management like that. So, I think the testing, to me, a lot of times I think it'd be interesting if somebody actually did cost benefit on things like that. We're always taught know what it is, but overall, how many of those tests are done that are actually helpful decision making, and that are actually even followed up on down the end of the road that make something different happen for the patient. I think the number is probably, so are you better off treating them? Well, it doesn't sound rigorous, but to me, it if you're that sick, I agree with you. The thing, going to speak out of both sides of my mouth here as well, it's always important to tell these patients, come back if you're sick. Patients want to believe that this is an oil change, or they want to believe that I come in, it's fixed, and I don't need to worry about it for 6 months or 5,000 miles, and I'm good to go. But it isn't. And, the thing you don't want to have is the patient you tell, thanks for coming to the ER today, see you around. And then you find out they die the next day. They don't come back. They struggled all night. They couldn't, survive. You got to always give that message to these patients that, hey, if things are not going well, I want you to come back. Or if you don't want to come back and see me because you're mad at me, go see somebody, because, the stakes can escalate quickly, and they can be high stakes for these patients. Even though not necessarily the greatest fan of that visit in the office when the patient comes back and says, hey, I feel terrible, and you told me don't worry about it. Now they're sick and they're, I'm going to have to go to the hospital or something, and they're not happy. That said, that's a better scenario than missing it. So come back at worse. And testing, again, I really think you have to start to develop in your back of your mind that sense of, is this test going to help my patient in some way? And sometimes that's an easy call, and a lot of these things, because they're going to play out before results come back, or they're going to play out, the window to take a drug is going to play out. You're probably going to have to end up on the side of treatment. What you don't want to do is potentially miss somebody who that treatment make a difference.
I always think sometimes it's faster, it's easier to just write the script than it's done. But I think that the better thing to do is to actually take more time to educate the patients, and then they just understand a lot better. It's just much faster to hand that script to somebody and they're out, but then we're lacking providing them anything that would be beneficial to them once they leave our office to know when to come back or when to go to the hospital. So I agree with you.
I think there's that. And I think there's the, sharing the decision. I won't say fortunately, but I mean, antibiotics also have their own reputation now for C. diff. They have their reputation for diarrhea. So they're not without problems. Got to give your patients benefit of the doubt. Patients are increasingly savvy. I know people are frustrated with their self-education, but, I think it's approach them like you would approach, a colleague and help them try to understand why you're making this decision, like any decision, and, make that decision together. Use all the information you can and just give it the college try, because there's some people who are going to.
Talking about antibiotics, I know that there's a lot of concerns about growing antibiotic resistance. So, I mean, you talked about this a little bit, you touched on it. It's really about balancing then the treatment with antibiotic stewardship. So do you ever in the hospital, I'm just wondering, do you review the antibiogram in order to know what antibiotic you should be using based on what it is in your area? Or do you not really find that very beneficial?
Maybe this is a good topic. We could spend another hour talking about this. Because the issue is antibiogram. You look, let's be honest, it's a sheet of paper. So like any sheet of paper, you look at it once and whatever. The only time you remember it is when the next one comes. Next year, oh, there's an antibiogram. Let's see it. So, what you're doing when you think about stewardship is you have to do something that doctors, I think, and I put myself in this category, are bad at. And that is I have to look at it and ask myself, is this patient really patient? This is a really critical point, I think, for all practitioners going now in the hospital and in clinic. Because now, patients come in, myself, wasn't that long ago, I wasn't taking any medicines. Now I'm taking 5 or 6 medicines. And, you start wondering, my blood pressure's low. I really need two drugs to control my blood pressure. And I think stopping medicines is going to be its own issue. And it doesn't matter. Antibiotics are a great example because in the hospital, we're using penicillin, kill them, knock out big antibiotics that lead to, nasty gram-negative infections. So it's really important to stop. But I think it's equally important in the office, does that patient really need allopurinol? Does that patient really need all these routine things that is PPI appropriate, for example? I think that's really an important thing. And going forward will continue to be because these medication lists just exponentially grow. Doctors don't like to stop medicine. I don't stop medicine. I'll stop it for myself, but not for my patient.
You touched on this also in the beginning, with multiple vaccines now available for influenza, pneumococcal, and then RSV for certain populations. How do you really counsel patients in this day and age about respiratory illness prevention using vaccines? And then who should receive them, who should not, and when? Are you just following guidelines for that, or are you looking at your patient population more so?
So I think this is one where it'd be nice to have this kind of conversation with patients about, this television philosophy of care and all that sort of thing. But I think, we've talked about a bunch of illnesses that have no specific therapy. So the only thing that's going to get you through these illnesses is your immune system hopefully being ready. And really that's vaccination. So right at the outset, want to say that this is not a political statement, nor is it a statement saying that vaccines are perfect. They have caused people problems. There's no question about that. That aside, if you're looking at, the role of vaccines in civilization and the lifetime of the human being, I don't think there's any intervention out there that we're doing today that has a better cost effectiveness ratio than vaccines. So if you look at it just objectively and say, well, we're building a new hospital and we're looking at cost benefit for our cancer unit, everybody would be like, oh my God, cancer unit. We need to have that cancer unit, right? But for most cancers, do they have the benefit that taking a vaccine would have for preventing a infectious illness? Does the chemotherapy have that same type of benefit? In a global sense, the answer is we do have successes. Though not picking on oncologists here or cath labs, just take your pick. All these modalities are out there that we spend great tons of money on that offer a very limited return compared to what vaccines can offer in general. Immunocompromised patient, medical comorbidities, particularly respiratory, cardiac illness, diabetes. These are reasons to get your patient vaccinated. I go along with, I can't swim against tide. I would go along with the guidelines. And, the guidelines are basically, I feel good about the guidelines that are back to the old guidelines. The old guidelines were influenza 65 or over yearly. I think that one's pretty easy. Now, when in preparation for this, I was looking at CDC stuff that was just updated recently, and they were talking about age 19 to 64. Yeah, get one. And I don't know, I don't know what to say about that, except, I don't think it's necessarily bad. I don't know that it's necessarily good either. Well, many of them, if they don't have comorbidities, again, life is life. You're not going to go through life without stubbing a toe or getting an illness just to say, I want to prevent you from ever getting influenza. I think that's an individual call. But so, influenza, yes, RSV, again, comorbidities, if you're in your 60s, certainly if you're in your 75 or greater, I think the recommendation for COVID, the recommendation is out there, one or two shots, recent shots, if you're under the age of 65, 2 shots, I guess yearly, I guess 6 months apart, if you're 65 or older. And then we really haven't even touched pneumococcal. I looked at it, and pneumococcal vaccines used to be simple. Now there's so many out there, I don't even know what to tell you, except that, again, I think the important thing that's different about pneumococcal to think about is the pneumococcus is not necessarily what we think about when we think about vaccines, and not to get into the tons of vaccine. People think about a vaccination as like a superhero's cloak. So if I get my vaccination, I'm not getting influenza. That's not really true, right? You're going to still get influenza. It's just not going to be what it was. Pneumococcal is like a step removed from that, because pneumococcal is really taking it because I don't want bacteremia with pneumococci. I don't want meningitis. I don't want endocarditis. I don't want things like that. So it's going to help you get better. But all of these things are basically there just to rev you up, be ready. So yes to vaccinations. I think, again, in the right population, you want to follow the guidance.
Thinking about red flags or warning signs, what are things that would prompt you to tell other practitioners when to recommend hospitalization? Let's say the patient's going, to see someone in an outpatient clinic. When should they be hospitalized for respiratory illness? And then when to recognize when is the time to actually refer someone, like out of a family practice into a pulmonary practice to be seen?
So red flags, I think, high fever, low blood pressure, that really sick-looking patient, the hypoxic patient. Those are ones that are there. Another tough group, the non-improving patient. Patient didn't get better, or the patient who failed outpatient therapy. These are people who I think you're really going to be thinking about for. Referral, basically, the duration of these illnesses and the fact that they're going to play out, you can't get a referral to a specialist in any specialty in the United States faster than maybe a couple of weeks, unless, we had a relationship. You could call me and say, hey, can you see this person? I would do that. But a lot of that's gone in the system. So now the person's going to be dead by the time they get my referral in the office, right? Or to be in the hospital. So most of those cases are cases where I'll see them in the hospital. It'll be family practice doctor would feel comfortable if you were involved, or the hospitalist wants you involved. And, obviously that's what we're here to help do. Or, we think they have a pleural effusion. But that sort of thing is really almost more of an inpatient phenomenon, because in the outpatient world, we just don't have a system that allows us to do that.
When you're talking to your patients and you're, whether or not you're giving them antibiotics, what do you tell the patients and the families to recognize when home management really is no longer appropriate and they should be doing something like going to the hospital or a walk-in clinic or something different?
I think that's a great question. And I think don't sell your patients and their family short. So again, patients and families have a generalized understanding, feeling that they're not getting better or something is really amiss and I need to do something about it. And I think, these are always challenging patients. This is a patient who's fit in at 4 o'clock on Friday. This is the patient who call them back when you're done with the office, or call them back in between. So you kind of end up feeling kind of frustrated when you tried something for them, whatever. And I think this is really one where the patience of the practitioner, not patients as in people, but patients as your patients, is really important and will make a difference for the life of your patient and your relationship with them as a satisfied customer. Because this is a situation where, hey, Doc Mazurek saved me an admission, or Doc Mazurek saved this, or he admitted me and it was the right thing to do. This is stuff that people remember about you. So, again, I guess the biggest thing would be they're not getting better 3 to 5 days down the line, as a general guide to say, if you're not getting better in a few days, or certainly if you feel worse, then you got to reach out to me or go to the ER. Or, again, if you're able, increasingly not because we're employed and we're not self-employed, but if you're able to create that flexibility, again, that's the stuff that really had the loyal patient buy-in, because the patients were always like, hey, so, Julia fit me in at the end of the day. And because she saved me any other visit, or she saved me, I felt reassured, I got a med that I needed to start. I think that's really important.
Thanks so much for all that information. As we wrap up, can you just give us the most important 1 or 2 POWs or pearls of wisdom to our listeners that they can use in practice about managing respiratory illnesses this fall and winter season?
Yeah, so I think a few points. Keep in mind that these are on their own time. So, it's science is not magic. So people will have variable degrees of how sick they are, and later can look and be sicker than they were on Saturday, now that it's Tuesday. And be ready to act on that, and be ready and almost proactive when talking to them and or their family members, so that they're not intimidated or unnecessarily angry about seeking out additional care, whether it's from you or somebody else. That would be one thing. A second thing I would generally say is, unless there's a lot of pressure for a diagnosis and it's a swab that's going to be pretty easy, pretty cheap to do, I would save testing for escalation of care, or for the patient who's not improving, or for a patient where if I'm really on the edge about, am I going to give them therapy, then I think I would avoid testing other than that. Frankly, again, you want to know what it is and what you're going to do. I think the third thing is then that idea of good patient discussion, good patient education, so that these steps are not magical or mysterious to them, so that you're there saying, Julia, I don't think you need anything today. I'm glad you came in. I'll give you a work excuse because I'm sure you whatever, that kind of data before you go back to work. But this is why I'm not doing it, and this is why it's good for you that I'm not. So, these are not big scientific things, but I think they're big things for dealing with patients and feeling good about, responsible medical practice with patients.
Agreed. Well, I know that I've gained a lot of information and insight about how to maneuver the upcoming cold and flu season. So I appreciate you. I appreciate all that you have done to improve the lives of our patients. And thanks again for sharing your time, your knowledge, and your POWs with us on this video and podcast.
Julia, it's been my honor. Thanks for including me. Take care.
I also want to just thank all of our viewers. I hope that you come back to hear more pearls of wisdom. Until then, this is Julia Rogers wishing you joy today and every day.
For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at The Nurse Practitioner Journal and on X at TNPJ_journal. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Thanks for listening.